Doctors' offices across the country strangled by red tape.
There's so many things wrong with this system.
It seems simple. Go to the doctor. An expert identifies a medical problem and hopefully finds a solution. But that's when the system can take over. A network of people and policies outside the office that influence and even overrule that doctor's professional opinion. A convoluted system of red tape.
My very first question is, what is your insurance company? Can you imagine that?
Mike Phillips got caught up in the red tape. He remembers days in his early 40s when he felt twice his age.
Any type of normal activity got to be a strain. Something as simple as washing a car, you could do it, but later that night you just feel like you'd been beaten with a baseball bat. The back hurts, the arms hurts, the knees hurt, you can't stand up, it's hard to sleep, all of those things.
Doctors diagnosed him with psoriatic arthritis, an inflammatory autoimmune disease that has no cure, but can be managed with medication.
What you also learn is, unlike a broken bone, there's no test where you can go take and the doctor say, oh, you have this type of psoriatic arthritis and this medicine works. It's really a hit or miss, try different things and see what works type situation.
His doctor found the right medication that got control of his symptoms until his family had to change insurance companies, and he learned the drug that worked would no longer be covered unless he and his doctor proved his symptoms were not controlled by two of the new plan's preferred drugs.
They never gave me any medical justification for the switch whatsoever. It's just simply they have a list and they say you have to take two of these medicines before we'll approve another medicine. And there's no medical discussion, there's no back and forth with your doctor.
Phillips had to change drugs because insurance plans have what they call formulary lists that detail which medications the plans will cover. Those lists put together by pharmacy benefit managers, or PBMs, middlemen who handle prescription drug benefits for most commercial health insurance plans. The big three PBMs, CVS Caremark, Express Scripts, and Optum Rx hold more than 75% of the market. PBMs control which prescriptions insurance will cover, meaning sometimes what patients are able to take is in direct opposition to what a doctor thinks is best.
Well, and it's frustrating too, because as you learn, if you go to these different insurance companies, they all have what they call their preferred list, and they don't match up. So they're not medically created. It's not as if science and testing has proven these are the four best medicines. It's who they feel they're getting preferable or preferential treatment from. Those are the ones that are on their list.
It's a financial decision instead of a medical decision.
It's 100% a financial decision.
The PBMs, these middlemen, were designed to create buying power for insurers. Their argument, they save money by securing the lowest net cost for medications and encouraging use of those discounted drugs or cheaper generics before anything else.
And then in those instances where there's robust competition in a particular therapeutic area, right? So there's several different drug manufacturers making a treatment for a particular condition, and they all work equally well, then the PBM can use some of those process steps to try and encourage the physician and the patient to look to the most affordable, most effective option first.
Investigate TV analyzed standard drug plans published online by the three largest PBMs, looking at 12 types of commonly prescribed drugs. Our analysis shows why it might be difficult for a patient to take the exact prescription drug their doctor thinks will work best. For example, the brand name drug Synthroid, which treats an underactive thyroid, is a preferred choice on one list, but would most likely not be covered at all by the other two. The document showed restrictions even within generic drugs, excluding certain doses and manufacturers from their preferred lists.
They are all, in those instances where there's a lot of equally effective options, trying to encourage the use of the lowest net cost option. And so for a particular plan, it may be a generic for a particular condition. It may be a brand that's brought that discount down below the cost of the generic. That is a big part of the recommendation process.
While you may think the pharmaceutical industry likes these deals and negotiations, it too says PBMs have too much power over pricing and patients.
At times, are the PBMs getting in the way of doctors and patients and deciding for them which should be used?
Absolutely. I mean, there's no question. There's a reason that state AGs, state legislatures, the Federal Trade Commission, that bipartisan members of Congress are investigating PBMs right now because there's widespread concern about the impact that PBM practices are having on patients and their ability to access the medicines that their doctors say that they need.
Do they have too much control?
They do. I mean, we see that in terms of what medicines do patients get, how much do they have to pay, and what hoops do they have to jump through to be able to access those medicines.
There's a lot more to medicine than checking boxes and making money.
Rheumatologist Dr. Madeline Feldman has been an outspoken critic of PBMs.
You can prescribe a drug, and if it's not covered in this formulary, your patient can't take the drug likely.
Exactly right. And people have said, yes, they're practicing medicine without a license. Well, their answer to that is, doctor, you can prescribe whatever you want. We're not telling you what to prescribe. We're just telling you what we'll pay for.
When we asked the PBM trade group, we got pretty much that exact response.
If doctors are saying, this is what I want you to take, and the patient is not allowed to take that because of a PBM, is that right?
I would challenge the premise of your question, because the patient is always able to take the medication that the doctor wants them to take. We're talking about what's covered by the insurance plan and how quickly the insurance plan may be able to respond to a doctor's request for an exception or for a course of action that may be different than the recommendation.
But financial decisions have physical consequences. Research shows that for patients like Dr. Feldman's, having to jump through hoops set by PBMs can cause measurable negative outcomes.
I've had patients that have lost control of their disease. I've had patients that have had to go on higher doses of steroids, and their blood sugar goes up, their blood pressure goes up.
PBMs claim these situations are outliers.
So you think these are exceptions that we're talking about?
I do.
And not happening a lot across the country?
I think that for the most part, millions and millions of patients the system works smoothly for.
But hundreds of comments to federal regulators we read through paint a different picture. One where doctors across the country allege the red tape put in place by PBMs is hurting their patients.
It's not against the law. As I like to call it, it's perfectly legal and perfectly wrong.
And patients like Mike Phillips are left tangled up in the debate over who really has permission to prescribe.
Use some common sense. It's okay to save some money. It's okay to review these things, but when a medical doctor who's been treating a patient on something like this for years tells you he needs to stay on the medicine that he's staying on, listen to the doctor. At least ask for something more if you're going to switch, more than just financial reasons.